let's talk about positioning with subclavian and IJ, whether on the left or right. We need always to perform a chest x-ray. This is whether was TLC, triple lumen catheter, cordis, or dialysis catheter. You always want to confirm positioning, and exactly the way we talked in PICC lines. If you go back to my PICC line videos, it has to be at the tip of the superior vena cava, just right before entering the right atrium, and this is in perfect position. And you can tell this is a right IJ coming this way and eventually going to the superior vena cava, you know, where the subclavian meet, then brachiocephalic, then superior vena cava. And if you wonder what is this, this is a AT tube, endotracheal tube. It's also a good position, about 3 centimeters above the carina. As you can tell, that left IJ has to cross a longer distance. If it's here, it has to come right here, so it has to cross longer distance. And you need to know that when you perform the procedure, because you have to advance the catheter, whether subclavian or left IJ, more distance if you're placing that on the left side. If you wonder what are these are leads, the EKG leads. Okay, let's take another example. Okay, as you see here, we have a catheter, looks like right IJ, but it's ending way up. It should be right down here. So this is, if I can say, high riding, or it's not in good position. This catheter need to be pushed maybe 3-4 centimeters down here. But remember, we don't like to advance catheter. We like to pull them. It's safer, because unless you're pretty sure about the sterility of the catheter that outside the skin, of course nurses they almost always do a good job by keeping that clean and sterile. But if you are at any point in doubt, please replace the catheter instead of pushing it. But if you are pretty sure it's sterile, you can just cut the sutures and then push the catheter for a few centimeters. I'll talk about some of the procedure briefly later on about all of this. Let's continue. So this is not in good position. Okay. Here you see there is a catheter here, right here. This is a left IJ and it's ending on the left side. It's not doing the way it should end right here, right? So this is malposition. This is need to be replaced. This catheter need to be replaced. Now, in some rare cases, there is some anomaly where the superior vena cava is located on the left. But again, those are rare, and don't suspect it right away unless you keep doing central lines and every time it ends on the left. This is ET tube, endotracheal tube. And if you wonder what's this, this is an NG tube going all the way down into the stomach. It's in good position. And actually, this is a classic. This is how the critically ill patient chest x-ray will be looking. Don't expect normal looking chest x-ray. Let's continue. Here we have a catheter right here, and as you see, it's a large diameter catheter. This is most likely a left internal jugular temporary dialysis catheter. And again, it's ending on the left side. There is something wrong. It should be ending right in this area here. Again, this needs to be replaced. Also, these are pacemaker or a defibrillator. And there is a line here going all the way down. This is most likely an NG tube, although I cannot see the tip of it because again, with those x-ray, you need to play with the contrast to have better view of these lines. Let's continue. Now look at this. We have, it seems, an endotracheal tube here, and you see this line right here. I wonder if you see it, but it's coming all the way from the right, looks like right subclavian, and ending into the left. Again, this is weird because if you follow the vein, it should end on the right. Again, there are some anomalies that possibly happen. But when you see this, don't think of these rare anomalies, just replace it, try again. But if every time you do it, it's ending here, you start thinking about, is the superior vena cava is on the left, one of the rare anomalies, or is it going into, I think, the internal thoracic vein and something like that. But you need to suspect immediately. I would replace it and don't suspect these rare anomalies right away. Okay, here, as you see, we have two catheters, this left IJ and right IJ catheters. You see this is kind of larger diameter one, smaller diameter one. It looks like this is a dialysis. Again, we're just guessing, but it looks like, and this is a regular triple lumen catheter. You see this is in perfect position right here, but this is coming from the left and is not, should be the same area, so it's kind of a little bit higher than the way it's supposed to be, and if you want to be perfect, should be pushed here. Let me tell you though, practically, if this line is working, functioning well, when I say functioning well, that you drawing blood without any problems, and you pushing pushing medication without any resistance, and the way it looks like on the x-ray this way, I think we still can be okay with this position because it's very close, maybe 1 centimeter from perfect position. So you can have multiple lines. You can have two lines, TLC, triple lumen catheter and dialysis in the same vein. That's possible. Or you can have line here and line here. Remember, you need to check if you have other devices like pacemakers here, for example, or a permanent dialysis catheter, or permanent catheter, like tunneled catheter. You need to go to the other side. See what we have. Okay, here we have, you see this catheter looks like right IJ is way up. This need to be pushed probably by maybe 12-13 centimeters. I'm just guessing. I'll talk about this centimeter when I talk about the just briefly about the procedure, but this is not a good positioning, right? If you wonder what are these are leads and wires, not in the just on the field of the chest x-ray. Okay, again here it's interesting. See here, this is not a line, this is the wire. Somebody forgot the wire inside that we used to insert the catheter, and as you see, this is the wire has this hook here, and see this hook. So you need to make sure you don't forget that, because at the end, if you do, then you have to call vascular surgery or IR to go and pull this catheter. This is the ET tube, and this is NG tube going all the way down, and this is, you wonder what is this, and this is looks like a line that's not in good position, right? A lot of things not good in the x-ray. Okay, what do you think going on here? This is look clearly a subclavian catheter, and it's in perfect position, but what's going on? Look at this area here and this area here, and compare it to here, it's different. And see this border here, this is a large pneumothorax, with even midline shift to the left. This need immediate attention with a chest tube to prevent tension pneumothorax. The catheter itself is in good position, and if it's functioning, if drawing blood fine, you don't have to do anything with the catheter, just treat the pneumothorax. This happens, it's a complication of insertion of IJ, internal jugular and subclavian. The needle, if you don't take your precautions, can pierce the pleura and cause this pneumothorax. So that's one of the complications. Also the other so that's PTX, pneumothorax. We use in our notes PTX as pneumothorax. The other one is bleeding for IJ and subclavian as well as femoral. The bleeding in IJ and subclavian mainly happens in IJ when we hit the artery instead of the vein. In IJ it's easy because it's right there. You just put direct pressure for at least, I recommend, for 5 minutes, and sometimes longer if somebody is coagulopathic or on anticoagulation. The problem with subclavian, it's deep, the artery, you cannot put pressure, and if you hit the artery, especially coagulopathic people, you may cause a large hematoma. That's why in coagulopathic people, please do IG and avoid doing subclavian for this reason. In femoral, the main concern is bleeding. So with femoral, let me write it here, mainly bleeding, retroperitoneal bleed. So if you have somebody, you put a femoral central line or had a femoral access for angiogram or cardiac cath, and you notice that they're getting more hypotensive and tachycardic post the procedure, suspect retroperitoneal bleed, so you need to check their hemoglobin or HNH, what we call HNH, and of course resuscitate them with fluid. If there is drop in HNH, you give them transfuse blood, correct their coagulopathy if they are, and of course CT abdomen and pelvis. If you can give contrast, good. If not, just go do it without